Welcome back to the deep dive. Today, we're doing something a bit different. We are shifting gears into, well, full-blown exam mode.
Yes.
I really want you to just take a second. Imagine you're standing in the sterile, echoey corridor right outside the examination hall at Gujarat University.
I remember it well.
You're about to walk in for your MD anesthesiology finals. Your palms are sweating, just a little, and you know that waiting for you inside is either a massive 20-mark theory question or maybe worse.
Or worse, the external examiner in the Viva Voce, sitting there with that stern expression, just waiting to test your grasp of patient safety.
Exactly.
And it's a scenario every anesthesiology resident dreads, but absolutely has to master. The topic today is blood thinners, specifically anticoagulants and antiplatelet drugs. And let me be very clear. This is not a topic you can fudge.
No way.
The examiners know this stuff cold.
Why?
Why? Because we deal with it every single day. In the OT, in the ICU, in the pain clinic. It's our bread and butter.
So we're not just memorizing drug names today. This is a high-stakes study session. We're looking at the pharmacology, the clinical use, and, most critically, the anesthetic implications. We've got the books out, Miller, Morgan and Mikhail, Katie Tripathi, and, of course, the Bible for this topic, the latest ASRA guidelines.
Right. And I'm stepping into the role of your senior faculty today. My job is to make sure you don't just pass the exam, but that you sound safe.
Safe. That's the key word.
It is. In the exam, and more importantly, in real life, safety is everything. If you don't know when to stop Clopidogrel before a spinal blot, you don't just lose marks, you risk paralyzing a patient with an epidural hematoma. So the stakes are genuinely high.
Okay, let's lay out the roadmap. We're breaking this down into 4 parts to keep the answer structured, just like you would in the exam. Part A is the overview and the absolutely critical physiology. Part B is the arterial side antiplatelet drugs.
Right.
Part C, the venous side anticoagulants, and then Part D, the big one, the perioperative and anesthetic implications.
Excellent. Let's get straight to it, Ben. Part A, overview.
Okay, so scenario 1. I'm in that exam hall. The question on the paper is, classify blood thinners and discuss their anesthetic implications. How do I even start? I'm guessing I can't just write drugs that thin the blood.
Absolutely not. You lose marks in the first sentence. Blood thinner is a layman's term. It's what you say to a patient's family. In a postgraduate exam, you need precision immediately. You have to distinguish between the 2 main categories, and you do it based on the pathophysiology they target. First, you have your antiplatelet drugs.
Antiplatelet?
These are the agents that interfere with platelet activation or aggregation. They're primarily used to treat, and this is key, arterial thrombosis.
Arterial thrombosis. So we're talking about high-flow systems, aren't we? The so-called white clots.
Correct. Think of arteries as high-pressure fire hoses. The sheer stress is incredible. If a clot forms there, it's usually because an atherosclerotic plaque has ruptured, and platelets are desperately trying to patch that hole against this massive current.
So the clot is mostly made of platelets.
It's platelet-rich. So think myocardial infarction, stroke, and of course, keeping coronary stents patent. That's the world of antiplatelets.
And that second category?
The second category is the anticoagulants. Now, these agents, they target the coagulation factors, the cascade itself.
The Roman numerals?
The Roman numerals, yes. And they are primarily for preventing red clots in, low-flow venous systems.
So like a deep vein thrombosis, a DVT.
Exactly. Or a pulmonary embolism, a PE. Or preventing a clot from propagating where there's stasis, like inside the atrium during atrial fibrillation. This distinction, antiplatelets for arteries, anticoagulants for veins, is the absolute fundamental framework. If you confuse those 2 in the first paragraph, the examiner has, well, they've already mentally moved on.
And for us, as anesthetists, the relevance is this constant tightrope walk. You're balancing the risk of a catastrophic thrombotic event, like a stent closing up, against the risk of surgical hemorrhage.
And more specifically, the catastrophic risk of a spinal or epidural hematoma when we do neuraxial anesthesia. That is the lens through which an anesthetist must view these drugs. It isn't just about bleeding, it's about where the bleeding happens. A bleed in the epidural space is a disaster.
Okay, that makes sense. Let's move to section 2, the physiology of hemostasis. This is marked very high yield. We can't talk about the drugs until we know the targets. Now, the textbooks, they always talk about the Cascade model versus the cell-based model. Which one do I need for the exam?
You need to acknowledge both because they serve different purposes. The Cascade model, that classic Y shape of the intrinsic and extrinsic pathways.
Joining at the common pathway.
Exactly. That model is vital for understanding our lab tests. The PT test measures the extrinsic side, aPTT measures the intrinsic side. But for understanding how hemostasis actually happens in the body, in vivo, and where our drugs really work, the cell-based model is frankly more accurate.
So let's break it down simply. Primary hemostasis. This is the platelet's job, right? The platelet plug.
That's it. So imagine a vessel injury. The first thing that happens is the subendothelial collagen and something called von Willebrand factor, or VWF, are exposed to the blood. Okay. Platelets are just flowing by, and they adhere to this newly exposed surface. This adhesion, this first grab, happens via a specific receptor called glycoprotein-IB. Think of gpIb as the hook on the platelet that grabs the wall.
Got it. gpIb hooks onto the vessel wall, so they stick. What's next?
Once they stick, they get activated, they change shape. They go from being these smooth little discs to spiky spheres, which gives them more surface area. And then they release their granules, which contain chemicals like ADP and thromboxane A2.
And that's a call for backup.
It's a recruitment drive. It calls in more platelets to the party. And then comes the crucial final step of this phase, aggregation. The platelets now need to link to each other.
And they need some kind of bridge for that, I assume.
They do. They use fibrinogen as the bridge to link up. And the receptor they use for this hand-holding is another glycoprotein IB.
Okay, I'm highlighting that for everyone listening. gpIb is for sticking to the wall. gpIIb is for sticking to each other using fibrinogen.
You've got it. And this whole process, this primary hemostasis, this is the target for our antiplatelet drugs.
Makes sense. Okay, so what about secondary hemostasis, the coagulation cascade?
Right. The goal here is completely different. The goal is to form a mesh of fibrin to cement that loose, unstable platelet plug into a hard, stable clot.
And this is where we get into the Roman numerals.
Don't panic about the numerals. Focus on the triggers. You have the extrinsic pathway. I call this the spark. It's triggered by tissue factor, or TF, binding to factor 7. It's very fast, but it only produces a tiny amount of thrombin.
And just enough to get things started.
Exactly. And the intrinsic pathway, that's the amplifier. It involves factors 12, 11, 9x, and 8. It takes that small spark and amplifies it into a huge burst of thrombin generation.
And both pathways eventually meet up.
They converge at the common pathway, which starts with factor X. Factor Z converts prothrombin, which is factor 2, into thrombin, which is factor 3, and thrombin. Well, thrombin is the boss.
Right.
It's the key enzyme. Its main job is to convert fibrinogen to fibrin, and that fibrin forms the mesh.
So to summarize, this secondary hemostasis, the cascade, is the target for our anticoagulants.
Precisely. And just as a final point on physiology, remember, the body has natural brakes. It have to. Otherwise, one small cut would cause your entire circulation to clot.
Things like antithrombin III and protein C.
Exactly. Antithrombin III, protein C, protein S, these are natural anticoagulants that prevent the clotting from spreading. We'll come back to them. But just remember, clotting is supposed to be a localized event. Our drugs make it a systemic issue.
Okay, physiology covered. I think that's a really solid foundation. Let's move to Part B, antiplatelet drugs. This feels like a huge topic for the Viva, especially with all the patients we see with stents.
Absolutely. So Section 3, Introduction to Antiplatelet Drugs. As we've established, these drugs inhibit platelet function. Their goal is to prevent that platelet-rich arterial thrombosis.
Now, Section 4 is classification. This is marked as exam core. So if I'm writing that long answer, how do I group them? What are the headings?
You categorize them by their specific mechanism. It's the most logical way. There are 3 main classes you absolutely must list. First, the COX inhibitors.
Aspirin.
The one and only, aspirin. Second, the ADP receptor inhibitors.
That's Clopidogrel and its relatives.
Yes, the P2Y12 inhibitors. And third, the glycoprotein-IB inhibitors.
The big guns from the cath lab.
The heavy artillery, yes. You can also mention others, like phosphodiesterase inhibitors such as dipyridamole, just to show you a breadth of knowledge. But those first 3 are the money.
Great. Let's dig into the mechanism of action in Section 5. Let's start with the COX inhibitors, aspirin.
Okay, so aspirin is acetylsalicylic acid. It works by irreversibly acetylating the cyclooxygenase 1 enzyme, or COX1.
Let's double-click on that word irreversible. Why is that the single most important word in that whole sentence?
This is a classic, beautiful physiology point that examiners love. Platelets are not true cells. They are just fragments of a larger cell, the megakaryocyte. They have no nucleus.
No DNA.
No DNA, so they cannot synthesize new proteins. They can't make new enzymes. So if aspirin comes along and permanently knocks out their COX enzyme, that platelet is disabled for its entire lifespan. It cannot produce thromboxane A2 anymore.
And thromboxane A2 is what calls other platelets to the party.
It's a potent vasoconstrictor and a powerful platelet aggregator. Without it, the platelet is effectively silenced.
So even though the drug itself, aspirin, is cleared from the plasma in just a few hours, the effect remains until the body physically makes new, unpoisoned platelets.
Exactly. And since the lifespan of a platelet is about 7 to 10 days, that is precisely why we have the 7-day rule for stopping it before major surgery or neuraxial blocks. You're just waiting for the bone marrow to replace the broken fleet.
That's crystal clear. Okay, moving to the second class. ADP receptor blockade, the P2Y12 antagonists.
So these drugs interfere with that ADP signal we talked about. If ADP can't bind to its P2Y12 receptor on the platelet surface, the platelet never gets the message to activate and express that gpIb receptor.
So it can't hold hands with other platelets.
They essentially become deaf to the recruitment call. They can't aggregate properly.
Now, in this group, we have the thienopyridines, that's Clopidogrel and Prodrug, and then the non-thienopyridines like Ticagrelor. What's the key difference I need to know?
So Clopidogrel is the prototype. And the critical thing to remember is that it's a prodrug.
Meaning it's inactive when you take it.
Correct. It has to be metabolized by the liver, specifically the CYP enzyme system, CYP2C19, to become active. And once it's active, it binds irreversibly, just like aspirin.
And because it needs the liver, that introduces variability, right? The poor metabolizers.
Precisely. Some patients have genetic variations in their CYP2C19 enzymes that make them poor metabolizers. In them, Clopidogrel may not be very effective at all.
Okay, what about Ticagrelor then?
Ticagrelor is different. First, it is not a prodrug. It works directly as soon as it's absorbed. And second, its binding is reversible.
Reversible, so its effect wears off faster once you stop the drug.
It does, which sounds good, but as we'll see later when we talk about reversal, it presents its own unique challenges.
Okay. And the third class, just to complete the list.
The glycoprotein IIIa inhibitors, abciximab, eptifibatide, tirofibon. These are, as you said, the heavy artillery. They block the final common pathway.
They stop the fibrinogen bridge from even forming.
Exactly. They physically block the gpIb receptor. These are usually potent IV drugs that we see used in the cath lab during an acute coronary syndrome, like a heart attack in progress.
Right. So Section 6, clinical uses. We've mentioned ischemic heart disease and stroke prevention, but the big one for us, the one that causes all the preoperative headaches, is post-stent therapy.
Dual antiplatelet therapy, or DAPT, usually aspirin, plus a P2Y12 inhibitor like Clopidogrel or Ticagrelor. This is absolutely critical for preventing a clot from forming inside a newly placed stent, a condition called in-stent thrombosis, especially with drug-eluting stents, or DES.
And if a stent thrombosis.
The mortality is massive. It's a catastrophic event.
Which leads us directly to Section 7. Anesthetic implications. A patient on DAPT for a stent placed 6 months ago comes in for, say, a hernia repair. What does the bleeding risk actually look like in the operating room?
It's rarely a big pumping artery that a surgeon can just tie off. The problem is microvascular ooze. Yes, the entire surgical field just won't stay dry. The capillaries just keep weeping blood. It makes the surgeon's life an absolute misery and can completely obscure the operative field.
Okay, now for the million-dollar question. Neuraxial considerations. This is the intersection of pharmacology and patient safety. Can I put a spinal needle in a patient on aspirin?
Generally, yes. This is a common viva question. The ASRA guidelines are quite clear that aspirin alone, at a low dose, is not a contraindication for performing a spinal or epidural anesthetic.
So it's considered safe.
It is, assuming there is no other coagulopathy. However, you must always ask about herbal supplements. Specifically, the GS, garlic, ginkgo, ginseng, they all have antiplatelet activity, and combining them with aspirin can definitely increase the risk.
Good point. Now, what about Clopidogrel?
Absolute no-go. For an elective block, it's a strict contraindication. You must stop Clopidogrel 5 to 7 days prior to the procedure. For Prodrug, it's even longer, 7 to 10 days. If you stick a needle in the back of someone who is fully loaded on Clopidogrel, the risk of an epidural hematoma is unacceptably high.
And what if it's an emergency? The patient is on Clopidogrel, they have a perforated appendix, they need a laparotomy now.
Then you do a general anesthetic. You secure the airway. You accept the increased risk of surgical bleeding. And if they were oozing uncontrollably on the table, the only reliable reversal for irreversible drugs like aspirin and Clopidogrel is a platelet transfusion.
You're just giving them a fresh batch of working platelets.
You are replacing the broken platelets with fresh ones that haven't seen the drug.
But I've read that Ticagrelor is trickier to reverse.
It is, and this is an excellent point for the exam. Because Ticagrelor and its active metabolite are reversible, they are still circulating in the plasma. If you transfuse fresh platelets, the drug that's already in the patient's blood will just attack the new platelets too.
So the transfusion is much less effective.
Much less effective. It is very difficult to reverse. That's a distinction that will definitely get you extra marks.
Okay, that's a fantastic overview of antiplatelets. Let's move on to Part C, anticoagulant drugs. The venous side.
Right. We're shifting gears now. We're targeting the Cascade. Section 8, Introduction to Anticoagulants. Before we even list the drugs, I think it's elegant to mention the body's own system.
You mean activated protein C?
Yes, exactly. Activated protein C is the body's own natural anticoagulant, and actually, it's a powerful anti-inflammatory enzyme as well. Its job is to find and degrade activated factors, VE and the eta. It's the natural brake on the amplifier.
So our anticoagulant drugs are basically artificial ways to apply the brakes.
That's a great way to think about it. We're trying to replicate or enhance this natural braking system to prevent that fibrin-rich red thrombus from forming in the veins.
Okay, Section 9, classification. Marked as very high yield.
Right. You need to be able to list these cleanly. You categorize them into parenteral, meaning injectable, and oral. Under parenteral, you have the heparins. And you must subdivide that into unfractionated heparin, UFH, and low molecular weight heparin, LMWH. You also have other parenterals, like direct thrombin inhibitors, such as bivalirudin, which we often use if a patient has a heparin allergy, a condition called HIT.
And for the oral anticoagulants.
You have the classic, the vitamin K antagonists, which basically warfarin and the coumarins. And then you have the modern era, the direct oral anticoagulants, or the DOACs.
Got it. So let's break down the mechanism of action in Section 10. Start with heparin. It's fascinating because, as you mentioned, it doesn't really work on its own.
No, it's a catalyst. It's an assistant. Heparin works by binding to a natural anticoagulant in our plasma called antithrombin III, or AT3. By binding to it, heparin potentiates it. It makes AT3 about 1,000 times more effective at its job.
And what is its job?
Antithrombin III's job is to go and inactivate thrombin, which is factor 2, and factor Zazak heparin just makes it do that job much, much faster.
So if a patient has a congenital antithrombin III deficiency...
heparin won't work. We call that heparin resistance. It's a key clinical concept.
Okay, now the big one. Unfractionated heparin versus low molecular weight heparin. What is the actual molecular difference?
I like to use an analogy. Think of unfractionated heparin as a long snake. It's a very long polysaccharide chain. It is long enough to wrap its tail around antithrombin III, and at the same time reach over and wrap its head around thrombin. So it helps AT-throm inhibit both factor IIIa, thrombin, and factor IIIa pretty much equally.
A long snake that can grab two things at once. And LMWH.
LMWH has been chopped up into smaller pieces. It's a short snake. It's long enough to bind to antithrombin III and help it inhibit factor IIIa, but is too short to reach all the way over and grab thrombin at the same time.
So LMWH has mostly anti-ZACA activity.
Predominantly anti-ZAGS activity with very little effect on thrombin. And this fundamental difference explains everything about how we monitor them, which brings us to Section 11.
Right, monitor.
Exactly. Because unfractionated heparin affects thrombin, and therefore the intrinsic pathway so significantly, we monitor it with the aPTT, the activated partial thromboplastin time. The therapeutic goal is usually 1.5 to 2.5 times the baseline control.
And LMWH?
Well, LMWH has very high bioavailability when given subcutaneously and very predictable renal clearance in most people. So we don't routinely monitor it.
Oh, there's a catch.
There is, and this is a classic exam trap. In patients with significant renal failure or at the extremes of weight like morbid obesity, that predictable clearance is lost. In those specific cases, you do need to monitor it, but you monitor it by measuring anti-factor Za levels.
So let me repeat that. Do not say aPTT for LMWH.
If you say aPTT for LMWH, you will fail the Viva station. I guarantee it.
Okay, message received. Now, what about warfarin?
Warfarin works completely differently. It inhibits an enzyme in the liver called vitamin K epoxide reductase. The liver needs reduced vitamin K to perform a final chemical step on some of the clotting factors to make them functional.
The vitamin K-dependent factors.
The vitamin K-dependent factors, 2, 7, 9XX. Warfarin basically blocks the recycling of vitamin K within the liver.
So it's not destroying its existing factors, it's starving the factory of a key ingredient for making new ones.
That is the perfect way to put it. And because it stops the synthesis of new factors, you have to wait for the existing factors already circulating in the blood to die off naturally. Factor 7 has a short half-life of about 6 hours, but factor 2 has a half-life of days. That's why warfarin takes 3 to 5 days to reach its full therapeutic effect.
And the monitoring is the classic PTI&R.
Yes. The prothrombin time, or PT, checks the extrinsic pathway, which is initiated by factor VII. The INR, or International Normalized Ratio, is just a way to standardize the PT result so that a result in Mumbai is comparable to one in London.
And the target INR is usually 2.0 to 3.0.
For most indications, yes. DVT, PE, atrial fibrillation, it's a bit higher, maybe 2.5 to 3.5 for patients with mechanical heart valves, especially in the mitral position.
Okay, and finally in this section, the DOACs, dabigatran, rivaroxaban, apixaban.
So these are the direct inhibitors. They don't need a middleman like antithrombin III. Dabigatran directly binds to and inhibits thrombin, factor III. The exabans, rivaroxaban, apixaban, directly bind to and inhibit factor Z. It's that simple.
And monitoring.
This is their main feature. Routine monitoring is generally not required or recommended, which is wonderful for the patient in terms of convenience, but it can be a bit scary for the anesthetist in the perioperative period because we don't have a simple number to look at to confirm the drug's effect is gone.
Right. Section 12, clinical uses.
It's broad. We use anticoagulants for DVT and PE treatment and prophylaxis. Stroke prevention and atrial fibrillation is a huge indication, and DOACs are now the preferred agent over warfarin for non-valvular AF.
But not for mechanical valves.
Absolutely not.
Sure.
For mechanical heart valves, warfarin remains the undisputed gold standard. DOACs are contraindicated in that setting. They were found to be harmful in trials.
Okay, this is great. Let's move to the final and maybe most important part, Part D, anesthetic and perioperative implications. This is pure application.
This is where it all comes together.
Section 13, perioperative management. A patient is on one of these drugs. They have an elective surgery scheduled. When do we stop them? Let's call it the days rule.
Okay. For warfarin, you stop at 5 days prior to surgery. This gives enough time for those long-acting factors to be cleared and for the INR to normalize. The goal is an INR of less than 1.5 on the day of surgery.
And for the DOACs?
For DOACs, it depends a bit on the patient's renal function and the bleeding risk of the surgery. But a good general rule is to stop them 48 to 72 hours beforehand. If it's a very low-risk surgery, maybe 24 to 48 hours is enough. If it's a high-risk surgery like neurosurgery or the patient has renal impairment, you'd want the full 72 hours or even longer.
Okay. Can you talk to me about the concept of bridging? What is that?
Bridging is the concept of covering the therapeutic gap. Let's say you have a high-risk patient, someone with a mechanical mitral valve, for instance. If you stop their warfarin 5 days before surgery, they're unprotected from forming a clot on that valve for several days. That's very dangerous.
So you need to substitute it with something.
Exactly. You substitute the long-acting warfarin with a short-acting anticoagulant. So you stop the warfarin, you wait for the INR to drop, and then you start them on therapeutic doses of LMWH or an intravenous heparin infusion. These can be stopped just a few hours before the surgery, minimizing the time the patient is without any anticoagulation.
But I've heard the trend for bridging is changing a bit.
It is. For many patients, particularly those with just atrial fibrillation, we're doing less bridging now. Several large trials have shown that the risk of major surgical bleeding caused by the bridging therapy often outweighs the risk of having a stroke during that short window. So it's become much more selective.
That's a key update. Okay, Section 14, neuraxial anesthesia and blood thinners, the time rule. This is pure ASRA guidelines, isn't it?
This is the most frequently asked, highest yield Viva question there is. You must know these numbers cold. We are trying to prevent a spinal hematoma.
Let's make a clear mental table. Huh?
Okay. For unfractionated heparin, if it's a subcutaneous prophylactic dose, say 5,000 units, you must wait 4 to 6 hours after the last dose before you can safely place the needle.
4 to 6 hours for UFH? What about LMWH, prophylactic dose, like enoxaparin 40 milligram once a day?
For prophylactic dose LMWH, you wait 12 hours.
12 hours. And for therapeutic dose LMWH, say enoxaparin 1 milligram per kilo twice a day.
For a therapeutic dose, you wait 24 hours.
So those numbers, 12 and 24, are non-negotiable lifesavers.
They are absolute non-negotiable rules. And you must remember catheter removal. The risk of causing a hematoma is just as high when you pull an epidural catheter as when you put it in. The same timing rules apply. If the patient received a dose of prophylactic LMWH this morning at 8 a.m., you cannot pull their epidural catheter until 8 p.m.
And after you pull it?
Good question. After you pull the catheter, you should wait at least 4 hours before giving the next dose of anticoagulant. You need to allow time for a small clot to form at the site where the catheter was.
Is there an examiner precaution here, something they might ask?
Yes. They'll ask, what if you get a bloody tap during the needle placement?
Meaning you hit a vein.
You've likely caused some minor vascular trauma in the epidural space. In that situation, you must communicate with the surgeon and strongly consider delaying the start of postoperative thromboprophylaxis for 24 hours. You need to be extra cautious.
That makes perfect sense. Okay, section 15, reversal. The worst case scenario. The surgeon is screaming, the suction canister is full of blood. How do we turn these drugs off?
Right. For heparin, the antidote is protamine sulfate. It works by a simple acid-base neutralization. Protamine is a strongly positive molecule. Heparin is strongly negative. They bind together and inactivate each other.
And the dose?
The dose is about 1 milligram of protamine for every 100 units of heparin still circulating. But you have to give it slowly. Given too fast, it can cause profound hypotension and even anaphylaxis. And a key point, protamine only partially reverses LMWH. It neutralizes the antithrombin effect, but only reverses about 60% of the anti-strom activity.
Okay. What about warfarin reversal?
If you have days, you can give vitamin K. If you have minutes, like in a trauma or for emergency surgery, you must give prothrombin complex concentrate, or PCC.
PCC.
It's a concentrate of the very factors that warfarin inhibits, 2, 7, IX, and X. It works almost instantly. If you don't have PCC, the older option is fresh frozen plasma, or FFP, but you need to give a huge volume of it, which risks fluid overload, a condition we call TACO.
And the DOACs. This used to be a major problem.
It did, but we have specific antidotes now. For dabigatran, the direct thrombin inhibitor, we use adagrasuzumab, brand name Praxbind. It's a monoclonal antibody fragment that just mops up the drug.
And for the ZAC inhibitors?
For the factor ZAG inhibitors, we have andexanet alpha. It essentially acts as a decoy receptor, tricking the drug into binding to it instead of to actual factors acta. It's new and very expensive. If these aren't available, we often use PCC off-label, with some but not perfect effect.
Good to know. Section 16, complications. Aside from the obvious hemorrhage, there's a big one with heparin, HIT.
Heparin-induced thrombocytopenia. This is a feared, immune-mediated reaction. The body forms antibodies against the complex of heparin and a protein called platelet factor 4.
And the paradox is that it causes clotting.
That's the deadly paradox. The antibody heparin PF4 complex actually activates platelets, causing widespread thrombosis, both arterial and venous. At the same time, the body clears these activated platelets, so the platelet count plummets.
So if you see a patient's platelet count drop by more than 50% a few days after starting heparin,
You have to suspect HIT. You stop all forms of heparin immediately, including heparin flushes and lines, and you must switch them to a non-heparin anticoagulant like argatrobin or fondaparinux.
right. Section 17, common exam questions and traps. What's a classic one?
The classic trap is, can you do a spinal on a patient taking aspirin? The student hesitates, they get flustered. The safe, correct answer is, generally yes, low-dose aspirin alone is not considered a contraindication by SRA, but I would always assess the whole patient, looking for other coagulopathies or the use of herbal medications like garlic or ginkgo.
Another trap.
How do you monitor LMWH? If you say aPTT, you're out. The answer is, it is not routinely monitored, but in specific situations like renal failure or obesity, an anti-factor ZAZA assay is used.
And one more on reversal.
How do you reverse warfarin for emergency neurosurgery? If you just say, give vitamin K, you fail to appreciate the urgency, it's too slow. The answer must be, I would give PCC for immediate reversal, along with intravenous vitamin K to sustain the reversal.
Excellent. Section 18, diagrams. For that 20-mark long answer, what should I draw to impress the examiner?
You should absolutely draw. First, draw the coagulation cascade. Just a simplified Y shape is fine. Label the intrinsic and extrinsic sides. Then take a different colored pen and put big X's where the drugs work. Put warfarin next to the liver where factors 2, 7, 9, X, and X are synthesized. Put heparinati hugging factors A, Cara, and C. And draw a separate little diagram of a platelet and put aspirin blocking COX.
What about a flowchart?
Yes, a simple perioperative management flowchart. A box for patient on anticoagulant, arrow to elective versus emergency, arrow to stratify bleeding risk versus thrombotic risk, arrow to bridge, pause, or proceed with reversal. A visual summary like that is easily worth 5 marks on its own. It shows you can think systematically under pressure.
That's incredibly helpful. It brings us to the end. Section 19, summary and exam conclusion. Let's wrap this all up.
Okay, here is your high-yield last-minute revision recap. 1. Antiplatelets are for arterial clots. Anticoagulants are for venous clots. 2. Aspirin is an irreversible COX inhibitor. The effect lasts 7 days. 3. Warfarin is monitored by INR, which checks the extrinsic pathway. Heparin is monitored by ATT, which checks the intrinsic pathway. 4. For neuraxial safety, you must adhere to the time intervals. Remember LMWH, 12 hours for prophylactic dose, 24 hours for therapeutic dose. 4. For neuraxial safety, you must adhere to the time intervals. Remember LMWH 5. For reversal, it's protamine for heparin and PCC for warfarin. 6. And the final, most important word in the exam, always prioritize patient safety. If you're ever in doubt about the timing for a neuraxial block, general anesthesia is always the safer and therefore correct answer.
Wow, that was a marathon session, but absolutely essential. To our listener out there getting ready for the Gujarat University exams, structure is your best friend. Don't just ramble, follow that flow. Physiology to pharmacology, clinical use, anesthetic implications, and finally, reversal.
And please remember, in the Viva, confidence comes from truly understanding the physiology, not from just memorizing the drug doses. If you understand why LMWH has a 12-hour rule, you will never forget it. If you understand why warfarin takes days to work, you will know how to manage it.
I have one final thought, kind of a provocation for the future. With the rise of these lab-free DOACs, is there a risk that we as anesthetists might become a bit complacent about coagulation status compared to the constant vigilance that warfarin and its INR demanded? Something to ponder.
That is an excellent question. The mechanisms of clotting are life-saving, but in our hands, the drugs that modify them are truly double-edged swords. You have to respect the pharmacology. Good luck in your exam.
We'll see you in the next deep dive.